I'm discussing the ocular sympathetic control for the eye and surrounding structures with reference to Horner's syndrome. First, I'll outline Horner's syndrome, then discuss the oculosympathetic anatomy, neurotransmission, and effector targets. Finally, we will wrap up by discussing the clinical testing for Horner's syndrome. The Horner syndrome was first published by Swiss ophthalmologist Johann Horner in 1869, describing a triad of findings with unilateral miosis, ptosis, and anhidrosis. Today, there are a few more documented signs which I will discuss. The causes for Horner syndrome range from benign to life-threatening, with these separated along the 3-neuron pathway. In an acute situation, this is an emergency and the patient needs to proceed for a CT or MR angiogram from the aortic arch to the circle of Willis. As you can see, the ocular sympathetic pathway detailed in green pen is very long and requires a large imaging field to capture it all. The first order central neuron originates in the hypothalamus, descending through the brainstem to the ciliospinal centre of Budge at level C8 to T2. The second order preganglionic neuron passes out of the ventral root of the spinal cord, proceeding up the sympathetic chain over the apex of the lung, up into the neck, terminating at the superior cervical ganglion at level C2-3. The third order postganglionic axon forms a plexus around the internal carotid artery with various targets detailed on the right of the diagram, and I will discuss these today. Important to note that the external carotid artery carries facial, pseudomotor, and vasomotor fibers. The sympathetic pathways turn the adrenergic system based on the neurotransmitter noradrenaline used at the postsynaptic junction. The postganglionic membrane receptors include alpha-1, 2, and beta-1, 2 receptors. Drugs and substances that influence noradrenaline synthesis, storage, reuptake, or release will influence the sympathetic response. Important to also be aware that neuropeptide Y and ATP have influence at this junction. So how do the lacrimal glands and sweat glands both release acetylcholine at the postsynaptic receptor, yet one is stimulated by sympathetic and the other by parasympathetic activity? Well, the sympathetic innervation of sweat glands proved to be the exception, exhibiting postganglionic cholinergic fibers. As a result, a Horner syndrome may result in either anhidrosis or lacrimation on the affected side. Sympathetic-mediated vasoconstriction to vascular beds in the face follows the same pathway. Here we see the striking appearance of hemifacial flushing with sweating on the contralateral side. The distribution for this can be useful for localizing the lesion, with lesions proximally to the internal carotid involving the whole side of the face, with lesions distally along the internal carotid affecting above the brow. Sympathetic motor supply to Mueller's muscle acting on the upper lid is responsible for up to 2 mm of elevation. Additionally, there is sympathetic supply to the lower lid retractors. Horner syndrome leads to an upper lid ptosis, reverse ptosis on the lower lid, and apparent endophthalmos due to narrowing of the interpalpebral fissure. Pupil size is under balance of parasympathetic iris constriction against inhibitory sympathetic action. Important to know that the inhibitory action is overcome by near and light reflex and is affected by emotional state and wakefulness. Horner syndrome leads to relative constricted pupil on the affected side turned anisocoria from unopposed parasympathetic action. In bright light, the sympathetic action is minimized, which makes it difficult to appreciate. In darkness, a dilation lag is appreciated about 5 to 7 seconds after lights out, helping differentiate from physiological anisocoria. Here, sequential photographs taken at 5 and 15 seconds after the lights are turned off highlight the dilation lag on the left. Intraocular pressure is controlled by the sympathetic nervous system. However, it is complex, occurring through a number of receptors responsible for aqueous production and drainage. In Horner's, there is a transient decrease in IOP, but the exact mechanism is not clear. Ocular blood flow is under autonomic control except for retinal blood supply. Sympathetic innervation causes vasoconstriction effects via alpha adrenoreceptors, responding to changes in intraocular or arterial blood pressure. It is thought that sympathetic action prevents overperfusion to the eye in states of high blood pressure. Clinically, with the Horner syndrome, we can sometimes appreciate conjunctival hyperemia due to loss of vasoconstriction. Clinical testing involves understanding of sympathomimetic eye drops acting at the neuromuscular junction. Epiclonidine, cocaine, and hydroxyamphetamine are the options available, having a direct or indirect action. Epiclonidine is a strong alpha-2 agonist, primarily used for intraocular pressure control, and its weak alpha-1 action has no effect on a normal pupil. However, in Horner syndrome, hypersensitivity develops with time at the postsynaptic membrane by increasing alpha-1 receptors. Epiclonidine will dilate and reverse the anisocoria while the normal pupil remains unaffected. With an obvious endpoint due to direct action, this is the gold standard test. However, it cannot be used in children due to risk of respiratory depression and is unreliable in the acute period until hypersensitivity has developed. Cocaine blocks noradrenaline reuptake. In the Horner's pupil, there is no noradrenaline secreted, and so cocaine has no effect, but dilates a normal pupil. As you can expect, this drug is not readily available, and so is reserved for children or acute cases. Hydroxyamphetamine use can help confirm the location of the lesion. For first or second order lesions, the Horner pupil dilates. However, a third order lesion will not release noradrenaline and will not dilate. But in an age where we can image the entire oculosympathetic pathway, hydroxyamphetamine use has now become outdated. Thank you, these are my references.